Thank you very much for the nice introduction, and good afternoon, everybody. After this previous talk, I will try to explain you that we are not developing a luxury technique, but actually try to develop a very efficient technique in the patient selection with patients with peritoneal cancer and eligible for HIPEC. Because it's a bit the dark zone, if I could say so, for radiologists. We make extreme progress, but the peritoneal cavity with the current modalities, be it conventional MRI, be it CT or PET-CT, it is still very difficult to go to the evaluation of these patients and to do very good preoperative evaluation. One of the examples is this, that we always say CT is cheap. Actually, we can apply it very easily, but if you would put the cost of the CT to the efficacy of predicting operability of the patient, probably we have a problem with applying these diagnostics. So we know that HIPEC patients, patients with peritoneal metastasis can be effectively treated with HIPEC procedures, but the patient selection is key in this. First of all, of course, the medical, clinical evaluation of the patient, patient characteristics, comorbidity, general condition, and then, of course, where we use mainly imaging for is the exclusion of generalized metastatic disease, lung or liver metastasis. But the third one is also extremely important, the extent of peritoneal disease. And actually there are two main issues that we have to take into account: the prognostic value, calculation of the peritoneal cancer index, which is usually done by the surgeon during laparoscopy or explorative laparotomy, but also the really anatomical locations that make surgery very difficult. For instance, if you have a peritoneal implant larger than 2 centimeters in the mesenteric root with encasement of the arterial structures and the mesenteric vein, it's very unlikely you will have a complete surgery. Also, the disease, retroperitoneal nodal disease, and especially suprarenal retroperitoneal nodal disease, is very difficult to detect. So what does the surgeon want to know from the imager, the radiologist? First, he wants to know if he has an ability to achieve complete resection. So this is an answer that we have to give with the scan. And the second is what he wants to know is prognostication. In our center, at least, a PCI larger than 15 is considered to be unlikely to be a successful procedure on the long run. So patients with a PCI higher than this are very unlikely to go to a HIPEC procedure. So what can MRI add for staging of peritoneal disease? Because in abdominal imaging, usually we know MRI as the problem solver. Very good example, rectal cancer, and also the detection of liver metastasis. Usually it has a limited field of view, only the lower abdomen or the upper abdomen. But MRI is evolving in an enormous way. We, of course, have anatomical imaging with it, and this is where often people stop. But we also have the targeted contrast, and a very good example is that of the biliary transporters, the liver-specific contrasts. There is perfusion MRI, which has a more limited functionality and more limited value in abdominal imaging. But what I'm going to talk about is the lowest one, diffusion-weighted MRI, which is clinically accepted, clinically useful, and that actually targets the cellularity of the lesions. So that's why I just put it a bit bigger. But you can see already the liver metastasis becomes very bright to the background. So why could we use diffusion MRI? What is the basic principle of it? Well, here on the left side, you can see inflammation. This is pancreatic inflammation in a groove pancreatitis. When we look at this scheme, actually, you can see water molecules who are green, water molecules that are red, and water molecules that are yellow. The yellow are the intravascular water molecules, and these you can ignore. What diffusion MRI is measuring is the Brownian movement of water, just how the water is randomly going between the cells. And as you can see here in this inflammation, there is a lot of space, many happy water molecules, and this is what we call facilitation of diffusion. Here we have a pancreatic cancer. As you can see, a lot of microstructural barriers, cells and vessels and so on. So you have a lot of water molecules that turn red, and this is what we call restriction of diffusion. The water molecules are restricted in their movement to do anything between these structures. And how does this translate? Simplified in a diffusion-weighted MRI, the inflammation or benign structure is not visible while the cancer becomes visible as a bright lesion. And it is this theory that we will apply to peritoneal seeding. So how does a protocol look like? This is a coronal reconstruction of the whole body diffusion. This is for detection of the lesions, coronal reconstruction of the T2-weighted imaging, and then especially for correlation of location, high-resolution contrast-enhanced imaging. And you can see very clearly the ball and the lining of the peritoneum. And this is especially very important to communicate with the surgeon because we really need to show where the lesions are. And also, just like PET diffusion MRI has a bit lower resolution, so we also have to add a high-resolution scan on MRI of the lungs. Importantly, this whole body protocol only takes 30 minutes. So this is a clinical efficient time for this type of examination. When we look what other things that we have to do is to see if this can become clinically efficient. Of course, your technician has to be happy, your patient needs to be happy, and your hospital needs to be happy. Well, it's for that all the last generation MRI systems have actually ability to do whole body imaging. And if you look at the setup, this is for an MRI bone scan. So we also want to include the legs. So we have 2 coils, each only weighing 500 grams on the patient. So it's not a burden for the patient. But for abdominal imaging, actually we only need 1 torso or body coil. The setup is very easy, and also with the latest generation MRI, they are no wide bore. So actually they have the same diameter like a CT scan, and claustrophobia is becoming less of a problem. And also there are some things in the area like lighting that make the patient more comfortable. So this is really something we have to think of. But also to be clinically efficient, of course, if we want to do peritoneal staging, it is also very important that we can detect distant metastases and distant lymph nodes. There are some data from literature, especially for the qualitative evaluation of lymph nodes, and this is a lot of studies who have been performed in Japan show that diffusion MRI is quite equal to PET-CT for lymph node staging in lung cancer. We also have studies performed in ovarian cancer and colorectal cancer in our own center. And actually what is important is that we have a very high negative predictive value for excluding tumor and acceptable positive predictive value, which is often equal to PET-CT. And especially this is the question that always rises. You can have it when an expert look at it, but we have done studies where we did reading by different radiologists, non-expert and expert radiologists, and actually the overall agreement was quite good to very good. So how does it look like on an image? I hope this works. Voila. So this is the coronal reconstruction. Just to show you the images, the brain is of course always somewhat visible as it has a hyperstructure with a restriction of the fluid. The torso, the abdomen, we go through the peritoneal cavity, and there we saw 2 lymph nodes that are really bright. When we go to the second patient, again, this is a patient with colorectal cancer. We scan through the coronal view of the body. We already see some peritoneal implants, but more importantly, when we go to the retroperitoneum, I encircle the lesions. You see the bright lymph nodes, but look also at the chest. All bright lymph nodes, and these were confirmed by endoscopy, esophageal endoscopy, to be metastatic. So, first of all, nodal metastasis is acceptable. And second, also distant metastasis. Well, MRI is very strong to detect liver metastasis, and there has recently been a meta-analysis of all the publications that have been done that compared whole body diffusion with PET-CT, and actually similar sensitivity and specificity is found compared to the PET-CT, with sensitivity spooled going up to 89% sensitivity and 95% specificity. So How will we do this in a clinically efficient way? Again, we use the diffusion together with the anatomy. This is a patient with 2 liver metastases. We have these nicely bright lesions in the liver, and they are corresponding to intermediate T2 or solid lesions and compatible with liver metastasis. This is an example of a patient with a lung metastasis and multiple skeletal metastasis. And also here we can see a very small pleural metastasis. It shows one of the advantages of the technique, that it combines a really high spatial resolution for a functional technique combined with high lesion conspicuity and very high contrast ratio. So why would we use then whole body diffusion for peritoneal staging? And I try to summarize this in this slide. It is not about detecting the actual peritoneal metastasis, because both the CT and the MRI would show this, but it actually, when you look at the lining of the peritoneum, this is a peritoneal cancer index estimation by the whole body diffusion. It says 19, non-operable. By the PET, it says 3, and the PET CT and the CT says 7, so route with the PET CT, this would also be around 7. What is the trick in this patient? It is a patient with a mucinous colon carcinoma, first of all, not easy to detect by PET, and it's also a patient after neoadjuvant chemotherapy. And this shows the advantage of the technique, both for primary diagnosis, but also able to stage the patient after neoadjuvant chemotherapy. And one of the major advantages that has been described in literature is the very high sensitivity for peritoneal implantations smaller than 1 centimeter. And usually these are the lesions that are clinically relevant to the surgeon. But there is a trick to it. It's a very simple trick, but it's a necessary trick to make the technique work, to see the serosal depositions on the small bowel. This is a volunteer at first when we developed, and here you can see all white dots on the small bowel. These are not peritoneal implants that we discovered by accident, but the diffusion MRI sees the contractions of the small bowel as implantations, because with the contraction, it's a kind of a movement restriction of the water. Then we try to give the patient peroral water. And as you can see, there are some metastases, but there is also functional signal in the water in the small bowel, so this was not enough. And what we did then is using an antispasmodic to stop the bowel movement, and we give peroral pineapple juice. And what you can see now very well in this patient are all the tiny deposits on the small bowel, and these are very important to detect. What makes it pineapple juice actually as a very efficient contrast medium for the patient, it contains manganese. Manganese is a metal, an MRI is a magnet, so metal makes an MRI image dark, and that's why it is so efficient in its ability. Patients like it, and sometimes I don't know, do they come for the scan or do they come to drink just the pineapple juice? But this is really something important to apply to the technique. You need a negative contrast agent in the small bowel to make it completely efficient. And these are things that we then, as a radiologist, have to learn from the surgeon. We have to talk very often with the surgeon, learn from them. How do you score it? Of course, you know the peritoneal cancer index. I didn't know it before I started with this technique. And very importantly, we will just do the same on the MRI like they will do with their laparoscopy. You can see here the confluent disease. So confluent disease is, for instance, scored as a 3. So what we will do, voila, is then just apply the quarters like they do on laparoscopy, and we will score the MRI. This is possible because you have this white on black image. So again, we will score it, and then we will give the total summation of the score to the surgeon attached to the descriptive report. So what did recent studies show? And I think there is a lot of important work that we are in debt to Russell Lowe from San Diego. He really works a lot on it. This is in 32 patients. When I made this slide, actually now he made a new study, again in the largest patient group where he compared it with CT. But most importantly, when you combine diffusion MRI with contrast-enhanced MRI, there is a high sensitivity and specificity for detection of peritoneal metastases in the separate subsites, but importantly, there was a very high match with the PCI. There has also been a very good study of Espada and colleagues from Madrid in ovarian cancer, and actually it showed, and this is although in a low patient population, a very important conclusion, 91% accuracy for predicting suboptimal surgery and actually selecting patients that would not benefit from debulking surgery. And this is a study we performed with whole body MRI recently in ovarian cancer, where there was a very high accuracy for the MRI or for peritoneal staging, higher than CT and PET-CT, but especially very important for nodal disease in the chest, the diffusion MRI was equal to the FDG PET for excluding nodal metastasis in the chest and the cervical areas. So what should we go to? Well, when you look on a patient basis, and this is a very interesting from de Souzan, study from de Souzan and colleagues, actually when you compare the diffusion MRI with the PET-CT on a patient basis, there is not a lot of difference. Both techniques will do very well in detecting peritoneal disease. But of course, for the treatment selection, we need to do more. And this is where diffusion MRI gains the advantage, and especially in areas, what they call the right supramesocolic area, often under the diaphragm, is very difficult for PET-CT to detect small lesions. It's very high sensitivity for difficult areas, the upper abdomen, to detect very small peritoneal implants. Like can be seen in these images, the PET-CT shows the big mass posterior from the stomach, but the diffusion MRI also shows the small deposits around the liver. So this is not about detecting disease, but about staging disease and showing the disease spread to the clinician and the surgeon. The other study of Russell et al. Shows that diffusion MRI has a much better correlation with the surgical PCI at laparotomy compared to CT. It's actually superior to it. When we look at the results, only the threshold for the PCI was different than what we use at our center. So what in the first patients that we did do? Well, first of all, diffusion MRI was very efficient in detecting distant nodal metastasis, excluding immediately patients that were irresectable for HIPEC, but these included also patients with really confluent peritoneal disease that were not immediately apparent at the CT. And we had 42 patients where a PCI assessment prior to HIPEC was then really valuable because these patients really went to laparotomy. It is importantly, we'll show this in the next slide, that we had a very high correlation with the PCI, but also very important that there was not really an overestimation of the PCI. So no patients were erroneously averted from surgery away. And this is, of course, a very important finding, as we don't want to preclude patients from the necessary treatment. Second, additional laparoscopy was only needed in 16 patients, so there was a decrease in surgical or the need for surgical diagnostic staging. So there was a good correlation, linear correlation between the PCI done by MRI and at laparotomy. And when we look at this in detail, actually, there was a good prediction of the patients that were operable with the low PCI. We had an underestimation in 5 patients. And these were 3 patients between 12 and 15. So this is a bit of a doubtful score and needs individual patient's decision to go to operation or not. And we really had an underestimation in 2 patients who were clearly inoperable. Both were after intense cures of chemotherapy, and luckily we got the feedback that we were wrong by the surgeon. And this is really very important, and we learn what we have to notice, why we were wrong, and we can find solutions to that. Importantly also, we had 4 patients who did go to laparotomy and an attempt for debulking surgery with HIPEC, for instance, because of young age, where we said that they had extremely high PCI, and all 4 were confirmed at laparotomy to have a high PCI. So how does this go in clinical practice? Well, this is often young patient. This is a patient of 34 years old, 2 years after already a HIPEC procedure. He is diagnosed with recurrent peritoneal metastasis. This is the FDG PET image that shows a few of localized new implantations, and he is sent to the MRI with the question if he is eligible for a HIPEC procedure. So when we look at the image, we look for the white dots. The big ones will be apparent. I will show you some smaller ones. Here we have one, small implantations. The big one you can recognize, small implantations, nodular implantation on the right flank, and a bigger one there separated from the kidney, and you saw two small ones passing by under the liver. The contrast is especially important to guide the surgeon to indicate possible areas where there will be need for a bowel resection. Voila. And this you will see, especially on the center line, this is important. The one we saw as a bright dot is here between the colon and the small bowel. This does not obviate surgery in this patient very likely, but this is something we have to say to the surgeon, watch out, there is a 5 centimeter deposit on the small bowel and you will probably need a resection. But overall, what we add to the report in this patient is the peritoneal cancer index score, which is 11 and no distant metastasis. And this information is added to the surgeon. So in this patient, debulking and HIPEC was performed and R0 resection was obtained. When we go to the second patient, this is of course the patient that I already showed, but now I want to go in more detail why this is inoperable. So again, a 56 years old patient after neoadjuvant chemotherapy. Of course, we know it's a mucinous adenocarcinoma, so they are not really FDG avid. So when we go to the diffusion MRI, the head of the patient, the torso, the abdomen, you can see the diffuse disease. Also, the diffuse disease on the bowel. These are all small dots on the bowel and around the sigmoid. And this is why we use the advantage of diffusion MRI over contrast enhancement. The lesion conspicuity. So this is why we have just left contrast-enhanced MRI, because you can nearly not obtain the image. Here you can see the disease on the, around the diaphragm, but it's very difficult to see the disease on the bowel. And this is the big advantage that the diffusion MRI has brought us in addition to contrast-enhanced MRI. But of course, it is important not only to focus on the peritoneal cavity. We know that this is the very important aim for the surgery. So here we also gave the PCI report 24, which is of course extremely high and difficult to have an R0 resection. And this is a patient who also received chemotherapy. This is the scan after the chemotherapy. But actually, it is unchanged compared to pre-treatment. So he was diagnosed with some peritoneal implants and 2 liver metastases. And also here, MRI was performed. And I will first show you the anatomy image just to locate the liver on the T2 image. So it is at this height. And then look at the diffusion MRI. Before we go to the peritoneal cavity, the liver is here. And you see already bright dots all over the liver. Also here. There, there. And in total, we actually measured 18 liver metastases in this patient. And this is the advantage recently published also. Microstructural imaging is actually independent of the effects of chemotherapy or radiotherapy. The inflammation is not visible in the scan, and therefore it is very excellent for post-treatment imaging. So to conclude, Of course, this is a technique in evolution. It is again not a new development, it is just a further development of already existing technology. And the technical evolution is there. If you look here for ovarian cancer, this is the first images of a pelvic MRI in 1986, 2013 pelvic MRI with high resolution, and at the end we are able to do whole body imaging. And it's like the evolution of man, but like always, we have to watch out that we don't hit the wall. And one of the things with MRI, and I think also radiological societies need to think about, it's hardware availability, we always say, and government, but probably also for us the choice lies there, what do we want to do with our MRI? Because at this moment, often it is more difficult to have a patient on the MRI with cancer, then it takes longer time than to have a patient on the MRI with a simple headache. And I think also as a radiologist community, we have to make the choices ourselves. The second also for diffusion MRI, because often you will see it doesn't work, it does work, but it's extremely important to look for the proper indication. It is meant to map disease, but of course this is not a perfect technique. There is a resolution limit of 3 to 4 millimeter, and for that, ovarian cancer, gastric cancer to lesser extent, and colorectal cancer, where we want to predict the treatment outcome and help staging of operability, is a very good indication. But in pancreatic cancer and cholangiocarcinoma, where a patient is really operable if there is no peritoneal disease, we are not able to exclude that for the full 100%. So there, of course, laparoscopy will remain the first modality. So we really have to be very careful with our indications. But last of all, it's also very important, and often we forget this, collaboration and communication. I'm very happy to have a very good collaboration with the Department of Surgery, Abdominal Surgery, and Digestive Oncology in our hospital. They are key, and communication is key. We need to learn from the surgeons, from the clinicians, and we have to give back also. And it's very important, these images need to be discussed at the oncologic board. But it's also somewhat in analogy with what I found on the internet. Often what we forget in radiologists is that we develop new techniques and it brings in new words, complicated words. And it's a bit like this dog has done something wrong and the boss is explaining to him you cannot do, but look, the dog only recognizes the name. And I think this is something as radiologists that we have to take into account. This is my colleague from Digestive Oncology, Hans Prenen, and he pointed it out to me. Look, you can look extremely difficult terminology, but I need to understand it. And that is what we need to do. So at the end, he only understands that there is a tumor. So we really have to communicate these images and also learn new how to read it and how to understand the new developments in imaging, MRI, CT or PET-CT. I thank you for your attention.